Page number 20, Clinical Therapeutics and Good Prescribing, box 2.5. Examples of pharmacogenetic variations that influence drug response. Genetic variant, drug affected clinical outcome. Pharmacokinetic, aldehyde dehydrogenase 2 deficiency, drug affected ethanol, clinical outcome. Elevated blood acetaldehyde causes facial flushing and increased heart rate in 50% of Japanese, Chinese, and other Asian populations. Acetylation, isoniazid, hydralazine, procarnamide, increased responses in slow acetylators up to 50% of some populations. Oxidation, CYP2D6, nortriptyline, codeine, increased risk of toxicity in poor metabolizers, reduced responses with slower conversion of codeine to more active morphine in poor metabolizers 10% of European populations, increased risk of toxicity in ultra fast metabolizers 3% of Europeans but 25% of North Africans. Oxidation, CYP2C9, warfarin, polymorphisms known to influence doses. Oxidation, CYP2C19, clopidogrel, proguanil. Reduced enzymatic activation results in reduced antiplatelet effect, reduced efficacy with slower conversion to active cycloguanil in poor metabolizers. Sulfoxidation, penicillamine, increased risk of toxicity in poor metabolizers. Pseudocholinesterase deficiency, saxamethonium, succinylcholine. Decreased drug inactivation leads to prolonged paralysis and sometimes persistent apnea requiring mechanical ventilation until the drug can be eliminated by alternate pathways. Occurs in 1 in 1500 people. Pharmacodynamic, genetic variant, drug affected, and clinical outcome. Glucose 6 phosphate dehydrogenase G6PD deficiency. Oxidant drugs including antimalarials, example chloroquine, primaquine, risks of hemolysis in G6PD deficiency. Acute intermittent porphyria, enzyme inducing drugs, increased risk of an acute attack. SLCO1B1 polymorphism, statins, increased risk of rhabdomyolysis. HLA-B5701 polymorphism, abacavir, increased risk of skin hypersensitivity reaction. HLA-B5801 polymorphism, allopurinol, increased risk of rashes in Han Chinese. HLA-B1502 polymorphism, carbamazepine, increased risks of serious dermatological reactions. Example and in Stevens-Johnson syndrome. Hepatic nuclear factor 1 alpha, HNF1A polymorphism, sulfonylureas, increased sensitivity to the blood glucose lowering effects. Human epidermal growth factor receptor 2, HAR2 or HER2 positive breast cancer cells, trastuzumab, increased sensitivity to the inhibitory effects on growth and division of the target cancer cells. Reactions, these present in a similar manner to acute anaphylaxis but are to a consequence of non-IgE mediated degranulation of mast cells and basophils or direct complement activation. Example aspirin, non-steroidal anti-inflammatory drugs, opioids, or 3 type 2 to 4 hypersensitivity reactions. These occur via other mechanisms such as antibody-dependent IgM or IgG immune complex mediated or cell-mediated pathways. Page 78. Examples of such reactions are listed in box 2.6. Drug toxicity, adverse effects of a drug that occur because the dose or plasma concentration has risen above the therapeutic range, either unintentionally or intentionally. Drug overdose, see figure 2.2 and page 224. Drug misuse, the misuse of recreational or therapeutic drugs that may lead to addiction or dependence, serious psychological injury such as liver damage, psychological harm, abnormal behavior patterns, hallucinations, memory loss, or death. Page 1240. Prevalence of ADRs. ADRs are a common cause of illness, accounting in the UK for approximately 3% of consultations in primary care, 7% of emergency admissions to hospital, and affecting around 15% of hospital inpatients. Many disease presentations are eventually attributed to ADRs, emphasizing the importance of always taking a careful drug history. Box 2.7. Factors accounting for the rising prevalence of ADRs are the increasing age of patients, polypharmacy, higher risk of drug interactions, increasing availability of over-the-counter medicines, increasing use of herbal or traditional medicines, and the increase in medicines available via the internet that can be purchased without a prescription from a healthcare professional. Risk factors for ADRs are shown in box 2.8. ADRs are important because they reduce quality of life for patients, reduce adherence to and therefore efficacy of beneficial treatments, cause diagnostic confusion, undermine the confidence of patients in their healthcare professionals, and consume healthcare resources. Retrospective analysis of ADRs has shown that more than half could have been avoided if the prescriber had taken more care in anticipating the potential hazards of drug therapy. For example, non-steroidal anti-inflammatory drug NSAID use accounts for many thousands of emergency admissions, gastrointestinal bleeding episodes, and a significant number of deaths. In many cases, the patients are at increased risk due to their age, interacting drugs, example aspirin, warfarin, or a past history of peptic ulcer disease. Drugs that commonly cause ADRs are listed in box 2.9. Prescribers and their patients ideally want to know the frequency with which ADRs occur for a specific drug. Although this may be well characterized for more common ADRs observed in clinical trials, it is less clear for rarely reported ADRs when the total numbers of reactions and patients exposed are not known. The words used to describe frequency. Page 20.